Hello everyone, welcome to Raaonline. So in this session, we're going to delve deep into the nervous system and try to uncover all the must-knows and the high-yield topics that we should definitely know if you're planning to clear our MRCP 2 examination. So, as most of you would already be familiar with, if you've gone through the question banks of MRCP 2, you would understand that MRCP 2 in a certain sense is going to be an extension of MRCP 1. Where you're expected to know the same length and breadth of topics that you've already learnt in MRCP 1, but your depth of knowledge is expected to be much more to clear MRCP 2. So, the details are very, very important, and also a lot of questions are going to be management oriented. So, in that sense, what we've done is we've taken up our MRCP 1 prep module and we've revamped it. We've added a lot more of high yield topics and made sure that this MRCP 2 foundation bundle makes you well prepared to take up the various question banks with ease. So this will be the perfect introductory beginners bundle which will help you to kickstart your MRCP 2 preparation. So by the end of these slides, you will be able to experience a certain sense of familiarity with most of the topics, which will help you to attempt the questions with ease and confidence. So let's move forward. So as I mentioned previously, this MRCP 2 module, we fashioned it in a manner where we've divided it into 3 bundles. The first bundle is going to be a foundation bundle where each of the topics will be dealt with respect to the high yield topics. The various management and diagnosis related pointers will be highlighted. The various templates and the pattern fits will be highlighted, and most of the important facts and must-knows will be discussed in the foundation bundle for each of these systems. And then you have the Q&A bundle where, very much like our MRCP 1 module, I will be taking you through a couple of questions. So we've planned about 50 to 75 questions this time for each system, and over the course of these 75 questions, you will be able to understand roughly what the approach is going to be. If you've already attempted MRCP 1, then most of you are already familiar with the approach, but then as I said, MRCP 2 is slightly trickier than MRCP 1 in the sense that the questions are going to be more elaborate, the case histories are going to be more elaborate, and there are going to be way more red herrings to throw you off the course. So, to help you pick these right points easily, to help you pick up the right clues easily, and to make sure that you're not misled by the red herrings, this practice of traveling with me through these questions in the Q&A bundle will definitely be helpful. And then we have the third most important bundle, which is the upskill bundle. Now, most of you would have realized that MRCP 2 is more challenging than MRCP 1, primarily because of all the images that come in MRCP 2. You're expected to know about the fundoscopy images, you're expected to know about various skin lesions, pictures of CT scans, MRIs, pictures of ECGs, pictures of pulmonary function tests. So you'll be assessed across all of these, and they carry a lot of importance. So that is what will be dealt with in the upskill bundle, where we will be trying to focus on the basic skills required to read an ECG, to pick up important problematic ECGs, and similarly likewise for other aspects like CT or MRI or X-rays. All this will be dealt with in the upskill bundle. And on that note, without further ado, we will dive straight ahead into our nervous system. So let's start off by trying to understand about localization. Here I'm going to give you some important pointers when it comes to localizing the problem. So as with neurology, the first question is going to be localization. So what are the important clues which are going to help you to easily localize a stroke in the brain? Now, whenever you have a contralateral hemiparesis with a contralateral upper motor neuron facial palsy, so both the deficits are on the same side of the patient. With or without a contralateral hemisensory loss, this is usually a middle cerebral artery territory stroke, where usually we can localize it to the internal capsule. When you have a contralateral lower limb predominant weakness with bladder involvement, this is an upper motor neuron kind of weakness, pure motor. Very likely this is the ACA territory stroke. So usually ACA territory strokes, this is how they present. Now, ipsilateral cranial nerve palsies or ipsilateral cerebellar features with contralateral hemiparesis. So basically, whenever you have crossed features with cranial nerve or cerebellar involvement on one side and hemiparesis on the other side, this is usually going to be your brainstem. So this is going to be your posterior cerebral artery territory infarct. Now, according to NICE, there are a few questions which focus on localization of the stroke, and they expect you to find out if it is a TACS or a PACS. Now, what are these TACS and PACS? TACS is total anterior circulation stroke, PACS is partial anterior circulation stroke, and then you have POCS, which is posterior circulation stroke. So, we are going to find out what are the clues we are going to use to determine whether your stroke belongs to TACS or PACS. So, whenever you have contralateral hemiparesis with contralateral upper motor neuron facial palsy, so both on the same side, with contralateral hemisensory loss with or without contralateral visual field deficits. Now, all this is going to be your total anterior circulation stroke. So, remember, what are the three components that are required to make a diagnosis of a total anterior circulation stroke? A, you need contralateral hemiparesis. On the same side, you need an upper motor neuron facial palsy, and on the same side, you need either a hemisensory loss or a visual field deficits. When these are present, usually along with some dysfunction in higher mental functions with aphasia, then this is going to be dominant hemisphere total anterior circulation stroke. Now, when you have minimal high motor function involvement and no aphasia, then this is usually a non-dominant TACS. So, remember, whenever you have on the same side, so let us say right and left. Now, on the right side, let us say you have a upper motor neuron facial palsy, you have hemiparesis, you also have hemisensory loss. Okay. Now, this, if it is associated with aphasia and higher motor function involvement, then this is going to be your dominant left-sided total anterior circulation stroke. If this was absent, then this is going to be your non-dominant left side total anterior circulation stroke, in which case your patient was very likely to be a left-handed individual. Now, of these, I told you the three elements, right? Of these, if only 2 out of the 3 elements are present, which means, let us say your patient had only upper motor neuron facial and hemiparesis, or only upper motor neuron facial and hemisensory loss. In this manner, if they have any 2 out of the 3 elements, the 3 elements being facial palsy, hemiparesis, hemisensory loss, or visual field deficit. So, of these 3 elements, if your patient has any 2 of the 3 elements, then your patient has a partial anterior circulation stroke, which is called PACS. Now, a pure motor or a pure sensory syndrome. So, whenever you encounter a pure motor syndrome or a pure sensory syndrome with stroke-like presentation, then very likely you are dealing with LACS, which is lacunar anterior circulation stroke. Now, there are also other lacunar stroke syndromes. You have 4 such syndromes. You have pure motor stroke, you have pure sensory stroke, you have dysarthria clumsy hand syndrome, and you have ataxic hemiparesis. Usually, lacunar strokes are associated with hypertension. So, remember, whenever you have a pure motor or a pure sensory stroke, that is going to be your LACS, which is lacunar anterior circulation stroke. Now, whenever you have cerebellar or brainstem syndromes or loss of consciousness or an isolated visual field deficit in the form of ipsilateral, in the form of a contralateral homonymous hemianopia, then usually it is going to be a posterior circulation stroke or POC. So, sometimes I've noticed in the questions that the NICE guidelines expect you to pick up the stroke and diagnose it in this manner. You will have to identify if it is a dominant TACS, non-dominant TACS, LACS, or if it is going to be a PACS or POCS. Usually, these are the 5 options given. So, look for these clues. If your patient has hemiparesis, hemisensory loss, upper motor neuron facial palsy, all on the same side, plus or minus visual field deficits, very likely you are dealing with a total anterior circulation stroke. So, look for higher mental functions and aphasia. If higher mental functions are significantly affected and if there is aphasia, it is going to be a dominant TACS. If these are missing, it is going to be a non-dominant TACS. Out of these 3 elements, if only 2 are present, let us say hemisensory loss with facial palsy, then it is going to be a PACS, partial anterior circulation stroke. And whenever you have a pure motor or a pure sensory syndrome, that is going to be your LACS, which is a lacunar anterior circulation stroke. And finally, when you have a brainstem or a cerebellar syndrome, that is going to be your POCS, which is a posterior circulation stroke. Now, let's move on a little further down into the brainstem. Now, remember, in the brainstem, there are few clues which will easily help you to localize the stroke to the brainstem. So, first is going to be horizontal localization. What is a horizontal localization? So, horizontal localization is in the horizontal plane. Is it medial or is it lateral? Vertical localization is which part of the brainstem? Is it in the upper midbrain or is it in the middle pons or is it in the lower medulla? So this is what we are going to find out now. So one simple clue is, as far as vertical localization is concerned, make use of the cranial nerves. Now you already know for a fact that except for 1 and 2, the other cranial nerves are going to arise from the brainstem, right? So your 3 and 4 arise from the midbrain. So whenever you have hemiparesis with involvement of 3rd and 4th cranial nerves, you automatically are going to localize it to the midbrain. Now similarly, your 5, 6, 7 and 8 are going to arise from your pons. So whenever you have involvement of 5, 6, 7 and 8, you are going to localize it to the pons. And finally, your 9, 10, 11 and 12 are going to arise from your medulla. So whenever you have involvement of these cranial nerves, you are going to similarly localize it to the medulla. So this is one important clue where you are going to make use of the cranial nerves to determine the vertical localization. Okay, so the second one is the horizontal localization, where you will have to say if it is a medial midbrain or lateral midbrain, or medial medulla or lateral medulla. So for this, there are two things you are going to be making use of. One is going to be your cranial nerves again. The other is going to be, more importantly, your sensory tracts. Now one easy clue to remember is, we all know that medial lemniscus is the ascending tract which carries the sensations from the posterior column of the spinal cord. So basically, what are the sensory modalities the medial lemniscus is going to be carrying? It is going to be carrying joint position sense and vibration. Now your lateral spinothalamic tract is basically an extension of the lateral spinothalamic tract in your cord, which is carrying pain and temperature. Your medial lemniscus carries joint position sense, vibration and fine touch, and your lateral spinothalamic tract carries pain and temperature. Now, as the name suggests, your medial lemniscus is going to be medial, your lateral spinothalamic tract is going to be lateral, right? So, whenever you have involvement of joint position sense or vibration, whenever there is impairment of these posterior column sensations in your brainstem stroke patient, it is going to be a medial brainstem problem. Whenever there is going to be loss of pain and temperature, then tells you that there is involvement of the lateral spinothalamic tract. Therefore, the stroke should have occurred in the lateral brainstem. So, having understood this much, we'll go on into the finer details of brainstem stroke localization. Now, whenever, other important thing as I mentioned earlier, whenever you're saying there is a brainstem stroke, you will always have crossed findings. What do I mean by crossed findings? So, basically, you will have ipsilateral cranial nerve involvement and contralateral hemiparesis. So, usually this is the pattern that you will find. You will have cross findings where there is going to be cranial nerve involvement on one side and hemiparesis on the opposite side. So, whenever you have ipsilateral third nerve palsy with contralateral hemiparesis, you are going to localize it to the midbrain. Whenever you have an ipsilateral sixth nerve palsy, contralateral hemiparesis with contralateral loss of medial lemniscal sensations. Now, remember here, sixth nerve, I told you 5, 6, 7, 8 is going to be pons. So, sixth nerve with a crossed hemiparesis is going to be pons. In addition, they are telling you that there is contralateral loss of medial lemniscal sensations, which is basically present in the medial aspect of pons. So, this patient has a stroke in the medial pons. Now, ipsilateral lower motor neuron 7th nerve. So, focus here, this is the lower motor neuron 7th nerve with contralateral loss of pain and temperature. This is going to be your lateral pons. Now, 7th nerve again localizes it to the pons. Because there is involvement of the lateral spinothalamic tract sensations, this has to be the lateral pons. Now, 12th nerve automatically localizes it to the medulla. Now, in addition, you have loss of medial lemniscal sensations, right? So, whenever you have ipsilateral 12th nerve involvement, contralateral hemiparesis with contralateral loss of medial lemniscal sensations, that is going to be your medial medulla. And whenever you have 9, 10 and 11 involvement with contralateral loss of pain and temperature over the body. So, here you are finding that the lateral spinothalamic tract sensations are lost. In addition, you have ipsilateral cerebellar features, ipsilateral honors. So, this is going to be your lateral medullary syndrome. So, this is the basic approach to the brainstem stroke. A little bit into the details. Now, whenever you have ipsilateral third nerve with contralateral hemiparesis, this is your Weber syndrome. When you have ipsilateral third nerve with contralateral hemiparesis and the contralateral ataxia and tremor, this is going to be Benedict syndrome. Ipsilateral third nerve with contralateral tremor and ataxia alone, rubral tremor alone, is going to be Claude's syndrome. Ipsilateral or bilateral third nerve palsy with ataxia is going to be North-Nagel syndrome. So, 4 very important syndromes. So, of this, remember Weber's is very important. So, ipsilateral third nerve plus contralateral hemiparesis is basically Weber's. Now, ipsilateral third nerve with contralateral tremor or ataxia. So, just like Weber's, instead of hemiparesis, there is ataxia. That is going to be a Claude syndrome. Now, you put both these together. So ipsilateral third nerve plus contralateral hemiparesis plus contralateral tremor or ataxia. This is going to be, so basically a combination of the findings that were seen in Weber's and Claude's is basically your Benedict syndrome. And when you have ipsilateral or bilateral third nerve involvement with ataxia, that is going to be your North-Nagel syndrome. Now remember, the vascular supply for the midbrain comes from the posterior cerebral artery, your superior cerebellar artery and your basilar artery. So these are the major vessels which are going to supply your midbrain. Now whenever you have an upgaze palsy with convergence retraction nystagmus with a dilated pupil, this is your dorsal midbrain syndrome, also called the Perinaud syndrome. This is often not the presentation of a midbrain stroke, rather it is the presentation of a tumor sitting at the dorsal midbrain level, something like a penialoma. So this is how a penialoma would present typically, with a dorsal midbrain syndrome, also called a Perinaud syndrome, characterized by very characteristic upgaze palsy and convergence retraction nystagmus. And so remember, whenever you have hemiparesis with an ipsilateral third nerve palsy, this localizes it to the medial midbrain. Whenever you have tremor and ataxia, this localizes it to the lateral midbrain. Remember, your corticospinal tracts at your midbrain are slightly more medially placed than your red nucleus, which is more laterally placed. Now, this is the reason that when you have a third nerve palsy with hemiparesis, that localizes it to the midbrain, whereas third nerve palsy plus a rubral tremor or ataxia, which is because of the red nucleus, that localizes it to the lateral midbrain. So, remember this important point. So, in the midbrain, we know that presence of third, fourth nerve involvement localizes it to the midbrain. But in midbrain, what do you use to determine whether it is medial or lateral? You look for corticospinal tract involvement or for rubral tremor. So, if there is hemiparesis, it is medial midbrain. If there is a rubral tremor or ataxia indicative of red nucleus involvement, this is going to be your lateral midbrain. Now, moving on to pons. Now, pons is basically supplied by the paramedian perforators of the basilar artery, the superior cerebellar artery and the anterior inferior cerebellar artery. Now, ipsilateral 6th and 7th nerve with contralateral hemiparesis is your Maillard-Gubler syndrome, a very important pontine stroke syndrome. Ipsilateral 6th nerve palsy with contralateral hemiparesis is your Raymond syndrome. Ipsilateral horizontal gaze palsy with ipsilateral 7th nerve palsy with the contralateral hemiparesis. So, very similar to Maillard-Gubler, only thing instead of 6th you are having gaze palsy. So, this is going to be your Foveli's syndrome. Ipsilateral horizontal gaze palsy with ipsilateral ataxia and tremor with contralateral hemiparesis. This is going to be your Raymond-Sisson syndrome. Ipsilateral ataxia with contralateral hemiparesis and loss of pain and temperature is going to be your Mary-Fox syndromes. Now, of these, as I mentioned, two syndromes which you need to remember. One is the Maillard-Gubler, other is the Foveli's. Now remember, in Maillard-Gubler you have ipsilateral 6 and 7 with contralateral hemiparesis. Foveli's is very similar, only difference is instead of your ipsilateral 6 you are going to have your ipsilateral horizontal gaze palsy. That is the difference. Now, I know it's difficult to remember these syndromes and it may not be very important when it comes to MRCP2, but what is important is in determining the clues to determine whether you are dealing with a ventral pons or dorsal pons, medial pons versus lateral pons. So, ventral pons, remember, is usually associated with involvement of the 6th and 7th cranial nerve. Dorsal pons is associated with PPRF involvement. PPRF is the center for your horizontal gaze. What is PPRF? PPRF is pontine paramedian reticular formation. So, that is going to be present in your dorsal pons. So, if you look at the pons, you will find that ventrally you have the 6th and 7th nerve nucleus and dorsally you have the PPRF. So, whenever you have horizontal gaze palsy, instead of cranial nerve deficits, that is going to point towards a dorsal pons involvement. Whenever you have 6th or 7th nerve involvement, that is going to point towards a ventral pons involvement. Now, lateral pons versus medial pons, one important clue as we saw earlier, whenever you have lateral spinothalamic tract involvement, it is lateral pons. Whenever you have a medial lemniscal sensations impairment, that is going to be your medial pons. But in addition to that, here the cranial nerves themselves are also going to help. Now, you saw here that the 6th nerve is located more medially than the 7th nerve. Therefore, involvement of the 6th nerve basically points towards median pons and medial pons, and involvement of the 7th nerve points towards lateral pons. This is another important clue. So, the take home is in the midbrain we saw earlier that corticospinal tract versus red nucleus involvement is going to tell whether it is medial or lateral, right? So, in the what are the clues which tells you whether it is medial or lateral? In the midbrain, it is going to be your corticospinal tract is placed more medially, so hemiparesis will mean medial, and your red nucleus is situated more laterally, so your ataxia or rubral tremor will mean lateral involvement. Now similarly, in your pons, you leave the medial lemniscal and lateral spinothalamic tract sensations. We know that already. What are the other clues? So in your pons, remember the 6th nerve nucleus is situated more medially and your 7th nerve nucleus more laterally. So 6th nerve involvement points towards medial pons and 7th nerve involvement points towards lateral pons, and both these are going to be features of ventral pons involvement. So when I say medial lateral, I am talking about the sides, right? When I say ventral dorsal, I am talking about front or back. This is front is ventral, back is dorsal. So both these are part of ventral pons, and dorsal pons basically has your PPRF. So dorsal pontine lesions or strokes are going to present with gaze part. Now moving on to localization in the medulla. Medulla is largely supplied by the vertebral artery and the pica. Now loss of pain and temperature in the contralateral part of the body and the ipsilateral part of the face. So ipsilateral facial loss of pain and temperature, and contralateral loss of pain and temperature in the body with ipsilateral cerebellar features, ipsilateral horners, ipsilateral 9, 10, 11 palsy in the form of absent gag. This is our lateral medullary syndrome or the Wallenberg syndrome, where the culprit vessel is usually vertebral artery rather than pica. Now, whenever there is ipsilateral tongue wasting or deviation, which is indicative of ipsilateral 12th nerve involvement with contralateral hemiparesis and contralateral loss of joint position, sense and vibration, this is our Dejerine syndrome or your medial medullary syndrome. Here, the culprit vessel is going to be your anterior spinal artery. So this is very important and needs to be remembered. So for your lateral medullary syndrome, your culprit vessel is your vertebral artery or your pica, but for your medial medullary syndrome, your culprit vessel is going to be your anterior spinal artery. So here we saw that, just adding one more here, in your medulla, what are the other clues for medial versus lateral? We just saw which cranial nerve is located more medially. 12th is a part of medial medullary syndrome, whereas 9, 10 and 11 are parts of lateral medullary syndrome. So remember this. So we will move on. So here we are able to see that in your medially you have 6 and 12. So very easy, 6 into 2, 12. Multiples of 6 are medial. Laterally you have the other nerves. You have 7, 9, 10 and 11. Whenever you have an ipsilateral palatal weakness with contralateral, so whenever you have ipsilateral palatal weakness, that means your 9, 10 and 11 are involved. So you are already talking about a lateral medullary syndrome, right? Along with this, whenever there is going to be contralateral loss of pain and temperature, that is referred to as Everly's syndrome. Along with it, if there is ipsilateral paralysis of sternomastoid and trapezius, telling you that there is significant 11th nerve involvement, it is going to be a Schmidt's or Jackson syndrome. Ipsilateral palatal weakness with ipsilateral horners, ipsilateral ataxia, contralateral hemiparesis. This is going to be your Seston-Chennai syndrome. Now, as you will find out, this is very similar to our Wallenberg syndrome. The major difference being, in Wallenberg syndrome, instead of hemiparesis, what do you have? You have contralateral loss of pain and temperature, whereas here in Seston-Chennai syndrome, instead of loss of pain and temperature, you have contralateral hemiparesis. And finally, whenever you have ipsilateral horners, contralateral hemiparesis, contralateral loss of pain, temperature, joint position, sense and vibration with ipsilateral 12th nerve, this is your Babinski-Negot syndrome. So this is basically both medial and lateral medulla are involved on the same side. So this is a hemimedullary syndrome, Babinski-Negot hemimedullary syndrome, where one half of the medulla is knocked out. So here you have ipsilateral involvement of 9, 10, 11, 12, ipsilateral horners, ipsilateral cerebellar features. You also have contralateral hemiparesis and contralateral loss of pain and temperature in the body. So basically, Babinski-Negot hemimedullary syndrome is a combination of your lateral medullary syndrome and your medial medullary syndrome. So both together they form the hemimedullary syndrome. In your lateral medullary syndrome, only this region is affected, right? And in your medial medullary syndrome, only this region is affected. When both are affected, that gives you your hemimedullary syndrome.